Hello, everybody. I'm Rob Wallace here in St. Paul, Minnesota. I'm an evolutionary epidemiologist with the People's CDC, here with an update on the COVID-19 pandemic. This week, we'll cover the state of global COVID and the state of U.S. COVID. We'll also continue to explore the trade-off establishment public health practitioners are making between the expedient politics found in declaring a still ongoing pandemic over and the likely long-term damage to the very concept of public health. For global COVID, in the top graph, our world in data using WHO data reports us down to only 211,000 confirmed global cases the week ending June 21st. The bottom graph shows us at only 1,100 confirmed deaths. Are such data real? No. Too few countries are reporting in at this point. That's why COVID this week has moved to downgrade the soundness of these data to red alongside their validity. These data no longer offer even a big picture grasp of the global pandemic. Last episode, we showed one snippet toward the top of the list of countries reporting in, showing a list of 0 cases, including from countries of 25 million people or more. This week, we showed a list toward the other end of the alphabet. Among this matrix of 0 weekly cases, we see Turkey, the US, and the United Kingdom, with combined cases of less than that reported by the US Virgin Islands, all 0. Indeed, infectious disease modeler J.P. Wayland used wastewater data from BioBot and CDC seropositivity to project 200,000 new COVID infections arose in the US alone for the single day of June 14th. If these estimates are anywhere near reality, both global and US data should now be rated junk. That said, we see from the Economist data set of the 7-day average of excess deaths per 100,000, a flattening out toward pre-pandemic levels. No countries reporting June 22nd showed excess deaths beyond a half a person per 100,000 population. That indeed converges upon the notion of a lesser COVID pandemic, but not 200,000 for the entire world for the entire week. Using WHO data, our world in data shows weekly hotspots as of June 14th. Of the countries reporting in, parts of Europe were showing the highest incidence, but no more there than 300 COVID cases per million population. New Zealand and South Korea, on the other hand, were reporting 17,000 plus and 2,300 plus new cases per million that week. Something more along the lines of the BioBot estimates Wayland showed for the US. Indeed, our world in data warns that confirmed cases are lower than the true number of infections due to limited testing. Along with the countries in hatch marks reporting no data, many in the yellow, including the US and Australia, are, as we remarked on earlier, reporting no cases, as in 0, which we know isn't true. We keep soundness here in yellow only because the map is still showing increases in those countries reporting in. So a glimpse of reality remains. But such glimpses may only catch COVID rebounds in passing. China's current burst is hampered by its truncation in reporting. That extends back to its first Omicron surge in winter 2022, which is particularly problematic as repeated outbreaks are likely built into the epidemiological momentum, even as 90% of China's population is reportedly vaccinated and 85% were infected this winter. Now, to be sure, this isn't just a China problem. Indeed, we've seen rebounds the order of the day at multiple spatial and temporal scales. We see from these percent changes in caseloads the past couple of weeks, rebounds, they are in the warm colors, are still scattered across the globe. The Dominican Republic, Guatemala, Nicaragua, Panama, Suriname, Malawi, Malaysia, and the aforementioned New Zealand. So even off a lower floor, rebounds are still in play. That's an important enough point as to get us to set validity and soundness in yellow. The correction to come is that COVID this week will likely have to move toward reporting only those countries which are clearly engaged in surveillance, as we have been moving toward for individual US states. Now, such rebounds are oft woven into the better projections of how a pandemic might play out. Too many people are instead looking upon pandemics as a weird black swan event unlikely to happen, or as a matter of deterministic necessity that this pandemic is evening out into an endemic illness at both the level of individual immunity and broader epidemiology, as local public health experts proposed here in Minnesota. As if pandemics must practice the kind of regression to the mean we see in baseball averages from season to season or across a season, as if a probabilistic comfort or a teddy bear. Yes, attenuation is one possibility, but not a necessity for a virus that continues to evolve both continuously and in sudden lurches. Indeed, COVID-19, other pandemics, and climate change may more represent what's called regression to the tail. The typical distribution of events we see in our mind's eye, here in blue, is in reality now more like in the orange, with fatter tails of greater possibilities for catastrophic outcomes. By dropping both non-pharmaceutical interventions like mask mandates, intermittent sheltering in place, and contact tracing, and pharmaceutical interventions like concerted vaccination campaigns and free Paxlovid, the force of infection continues to plow through susceptibles, keeping the tails fat here. As management professor and economic geographer Bent Flubihe describes it, some distributions are so spread that they offer no mean or other centroidal measure in any distinguishable way. Indeed, the statistical tails are where the action is. One new extreme tops another. Perhaps in this context, in the emergence of a series of newly deadly COVID variants, including, as this Russian study suggests, those that have lost viral micro and RNA binding sites that the host cell uses to target the virus for destruction. We see here the decline in such sites in the increasing blues left to right, from the Wuhan strains to Omicron. Such directional selection down the statistical tail is as much a possibility as any wishful stabilization. Decision makers, Flubier writes, will want to do two things. A, cut the tail to reduce risk by mitigation, and B, practice the precautionary principle, that is, avoid tail risk altogether by overcaution, end quote. Instead, the pharmaceutical strategy many governments say they're pursuing instead of non-pharmaceutical interventions is faltering. The home rapid antigen test, turning public health into a matter of individual convenience, are notorious for false negatives. Here, medical doctor Pedro Larias reports 6 of such tests, one after the other, left to right, using 4 brands, A, B, C, D. A reports a COVID infection both times, B reports negative twice, and C and D lightly positive. Now, any positive means that you are definitely infected. But if this patient had only used a product B, they might continue to walk around presuming no infection, and so more likely to infect others. In the meantime, much of the world is at best vaccinated for variants no longer circulating. We see uneven campaigns in booster vaccination across the world. On the one hand, Peru, Uruguay, Argentina, Cuba, Belgium, Italy, Finland, and Japan show top-tier booster campaigns with 70 or more booster shots administered per 100 population. In contrast, we see near nothing in Russia, India, and Pakistan, those even reporting in from Africa, as well as mediocre campaigns in Central America, Spain, and Eastern Europe. This map seems like it hasn't changed much. With fewer countries reporting in, these campaigns appear largely to have ground to a halt. Indeed, the CDC reports the US stuck at 17% of its eligible population 5 years and older with an updated booster dose. We can see from this time series a combination of some countries no longer reporting in, but almost a universal tailing off of new vaccinations since spring 2022. Now, the thing is, we have seen some countries move up, including Peru and Italy, while others have fallen back, including New Zealand. So the mediocre vaccination campaigns, hand in hand with the rollback in the non-pharmaceutical campaigns that successful vaccination depends on, have allowed SARS-2 to continue to evolve out from underneath what few concerted COVID campaigns remain. Many new Omicron subvariants are now circulating across large expanses of the world. XBB 1.5 in blue is suddenly getting replaced by other XBBs, including in this batch, every country but Australia. For other countries, we're drawing from covariance.org. We see a wider mix in China, BA5, BA 2.75, XBB 1.5, and XBB 1.16. Malaysia is reporting that XBB along with XBB 1.5 and XBB 1.16. Singapore is hosting Omicron old-timer BA 2.75, XBB 1.5, XBB 1.6, and a new recombinant. Finally, here, Sweden is reporting the same, except no recombinant. But other Omicron sublineages are in play, including the appropriately named and fast-spreading FU.1 strain, which is an alias of XBB 1.16.1.1. Joining what Raj Narayanan shows is the global diversity of sequences the past 20 days as of June 25th. XBB 1.5 is still hanging on, leading the way in light blue, in part due to the sampling bias toward high-income countries. But we see many subvariants and sublineages in play, including many XBBs, like XBB 1.9.1 in forest green, XBB 1.1.6 in purple, and EG1 in red, among others. That the world is still hosting such a large zoo of variants makes this map green in both reliability and reality, even if not every single lineage has been sequenced. In the face of the declines in country reports that we started our broadcast with, one could use the molecular clock and the accumulation in genetic variation month to month shown here to estimate the total number of infections. That's a phylogenetics the People's CDC will look into, but such analyses are not easy to do from scratch. And the People's CDC is not a $12 billion a year federal agency like the CDC. The infections still accumulating in the millions are accompanied by 1 in 10 chance of long COVID. This recovered study of nearly 10,000 patients found 10% moving to long COVID 6 months post-Omicron infection, with 37 symptoms on the right, with adjusted odds ratios of 1.5 or more across 4 different symptom profiles on the left. Reinfection led to long COVID in 20%. The unvaccinated nearly doubled their risk for long COVID. So while vaccinations do not offer categorical protection, they do offer some statistical buffering. You better your odds, but only that. Even the vaccinated are still vulnerable to long COVID. Another new study shows the unvaccinated who were infected with a mild COVID infection also suffered alterations to their cerebral white matter. In contrast to other COVID brain studies we have reviewed here on COVID this week, this German team did not find worse cognitive functions within the first year after recovery. However, the study did detect prolonged neuroinflammatory responses to the initial viral infection and called for continued longitudinal study for possible long-term impacts. The big brain news, however, is out of Australia. A team there showed the fusogen protein SARS-2 uses to enter brain cells also causes host neurons to fuse together or with glia, or those are the non-neuron brain cells, and to fuse with them by both the soma of the neurons and their neurites. The team showed such fusion events damage neuronal function. Those are the fused cells on the left and the control cells on the right, with the graph showing the difference in the resulting combined cells, or syncytia. The fusion depends on the expression of the key ACE2 receptors SARS-2 targets across the body, and other accessory entry factors in neighboring neurons, such as TMPRSS2 and NRP1. The vast majority, around 90% of fusion events, produce synchronized neuronal activity with the overlapping of calcium ion peaks. So one fired neuron sets off its fused partner. The remaining 10% suffered a complete loss of neuronal activity, particularly those fused at their soma. The proximate objective of such fusion from the virus's vantage point might be to increase transmission of the virus. A more distal impact might involve host manipulation to influence host behavior, including host risk assessment. To what purpose is an open question. An important consideration that emerges from our results, the team writes, is that fused neurons remain viable, albeit with altered circuitry and function, end quote. Moving to a different organ system. For a study released in February, a Stanford University team found the lungs of COVID patients suffering shortness of breath looked like the lungs of patients suffering end-stage pulmonary fibrosis. The fibrosis, scar tissue, that developed in mice models the team infected with SARS-2 emerged out of the upregulation of key pro-inflammatory and innate immune effector genes CD47, IL-6, and JUN. The more active these genes, the greater the fibrosis. The team found blocking this mode of inflammation reversed the fibrosis. We can see here in the graph at top in green, no fibrosis developed in control mice over the month of this experiment, while mice in blue treated with doxycycline to induce the immune transcriptor factor JUN led to a quarter of the mice with fibrosis. The mice treated with doxycycline and a combo construct of human ACE2 receptor and a SARS-2 spike protein produced fibrosis in over 50%. We can see the differences between the treatments also represented in the histologies underneath. Finally, for long COVID for today, a Finnish team's review of the cardiovascular literature shows reinfection with SARS-2 compounds damage in the endothelium, the lining of the cardiovascular system, especially in patients with cardiac comorbidities to start. Depending on where the endothelial dysfunction is compounded, the resulting damage can produce macrovascular and microvascular thrombosis or acute coronary syndromes or damage directly to the heart. The team recommends treating at-risk patients with statins to lower cholesterol and inflammation. Now, to sum up long COVID, we need to ask ourselves whether we are prepared to risk losing brain, lung, and cardiovascular function this way. As the lung and cardiovascular studies show, some long COVID symptoms can be reversed, but only upon considerable damage, and with pharmaceuticals at this early date still only in development. The best treatment is prevention, not getting COVID in the first place. Turning to the US, the Walgreens COVID-19 Index of National Test Positivity covers both rapid tests and PCR. As of June 16th, we see positivity back up to a quarter of all tests Walgreens processes. Although the number of tests conducted is much lower than a month ago, and those state public health departments still reporting in are showing much lower positivity, something more like 5%. But we get a sense of the relative changes in positivity over time, and COVID is clearly still in the mix. The CDC reports the latest round of excess deaths associated with COVID during the pandemic in blue, and those associated with non-COVID causes in yellow, above the expected average deaths based in the 6 years before the pandemic in orange. The last excess death count shown here for the US above the threshold in the red pluses for both COVID and non-COVID cases is marked for January 21st. With the end of the declared emergency, counties and states are no longer obligated to report in caseloads and deaths. A decline in reporting that was already in motion, hand in glove with, as CDC weighs in, quote, decreased laboratory testing, increased home testing, changes in reporting practices, and asymptomatic infections, end quote. Instead, the CDC replaced the almost always all-green map of community levels with another nearly all-green map of percentage of provisional deaths due to COVID. We no longer have access to the raw numbers. Now, in this case, we did infer the numbers for Mississippi there in yellow. We averaged the weekly deaths for the state over the first 22 weeks of the year for which data are available, multiplied it by the 4.5% of deaths assigned as COVID-related, producing 28 COVID deaths for this week. Certainly a bit more than the 0 deaths the US reported to the WHO. And likely an underestimate for Mississippi, as many deaths are accruing as secondary impacts beyond the acute infection. Epidemiologist Isaac Michaels is continuing to map community transmission CDC abandoned, at least for his home state, New York. The state registered 25 confirmed COVID deaths the past week, 485 COVID hospital admissions, and a 4% positivity rate. So again, much less than the Walgreens estimate. We see 21 counties, especially along the southern tier, supporting high or substantial transmission based on test positivities and caseloads, up 10 counties in the past 2 weeks. Detecting SARS-2 in sewage wastewater remains in place. We see the levels of SARS-2 virus detected in the wastewater, in some ways a leading indicator of the pandemic for May 29th through June 12th. In the oranges and reds, we see plants at 60% or more of all the samples in SARS-2 detected taken nationally since December 2021 in only single plants in Washington State, Oregon, Oklahoma, Arkansas, Illinois, Michigan, Kentucky, North Carolina, South Carolina, Massachusetts, and New Hampshire. We see pairs of plants in Texas and New Jersey, and we see a handful of plants in that 60% range in New York State. But much of the country is under 20% in the distribution of samples reporting back to December 2021. So much quieter now than before. On the other hand, the more acute measure of changes in sewage loads over the past 15 days shows some areas heating up more than others. Along the West Coast, Idaho, Utah, East Nebraska, Missouri, throughout the industrial Midwest, here and there throughout the Southeast, and running hot and cold through the Northeast. These could be threatening spikes, or they could be increases off a lowering floor. Here are the 7-day averages of fractions of hospital beds filled by COVID patients in 3,400 plus hospitals reporting June 3rd through the 9th, mapped by the People's CDC's Les Schaffer. We see the Bay Area hit hard, a few hospitals in the LA region, with one hosting COVID cases in over 35% of its hospital beds. We see a few hot spots around Phoenix, a number in outstate New Mexico, Minnesota, South Carolina, and Upper Ohio. Still Birmingham, Alabama. The Northeast, other than Philadelphia, on the other hand, appears in contraction. We set both validity and soundness in yellow as hospitals differ in COVID definition and reporting efforts. And big picture, the number of hospitals reporting in is in decline, down 400 since we last looked. That said, we still get a sense of the regional pressure COVID is imposing on hospital capacity, and that pressure's change in time. With universal testing and hospital mask mandates ending, and CDC's move toward ending reporting hospital-acquired infections, it's likely the US will be going the way of other countries. A Harvard population medicine team showed for Scotland on the left and England on the right, hospital-acquired infections per 1,000 community infections on the top and per community onset COVID-19 missions on the bottom, spiked beyond the blue lines there when testing all patients for COVID upon admission ended. So you end COVID testing in hospitals, more people get infected there. The outbreak stateside continues to evolve, with here XBB 1.5 now getting replaced by other XBBs, including 1.16, 1.5.1, and 1.91, and the new arrivals of XBB 2.3 and 1.16.1 there in the reds and pinks. Here's the 21-day trend of all genetic sequences of detected sublineages in the US as of June 22nd, including their geographic origins. XBB 1.5 in blue is still ahead in states across the country, but beginning to give way to other XBBs, particularly XBB 1.6. Big picture, there are all sorts of other subvariants and sublineages circulating in such a way as to offer possible candidates for the next dominant variant or to contribute to the next recombinant that accelerates beyond both vaccine and population immunity. Declaring a prevalence lineage a softie, as was done here in Minnesota, doesn't mean new, nastier variants can't arise. We end with commentary on the continued collapse and even the notion of the public commons, any effort to intervene into public health problems, including the still ongoing pandemic, requires. The Washington reports on the overall retreat in COVID protection, even at the individual level. Quote, the mother of an immunocompromised teenager is traveling by plane for the first time since the coronavirus pandemic started. A scientist felt safe enough at last to attend a professional conference last week. Members of a meditation group for retirees are ready to doff their masks, even the woman with lung problems. Emboldened by the government's recent lifting of the public health emergency, the Post continues, Americans who have tried to be rule-following pandemic citizens for the past 3 summers are at last abandoning precautions as the coronavirus fades into a background threat, end quote. Even as the article also describes the various contradictions rolling up against the socio-psychological buffering here. Quote, available metrics suggest the virus is declining, although no one really knows how much the coronavirus is circulating given a drop in data collection, end quote. And affordable testing remains out of reach for many Americans now that the federal government has stopped mailing free kits and insurers are no longer required to cover them. While some people still have tests stockpiled, experts worry fewer chains of transmission will be broken as people stop testing when they experience cold-like symptoms or before big gatherings, end quote. Indeed, on more informal Reddit boards and Facebook COVID groups, the newly infected now register surprise. For instance, my boyfriend tested positive and is having severe body aches. I see the extreme pain as something that commonly can't be relieved easily. He's an ex-Marine linebacker, and I only say that to gain context to his pain tolerance. He says nothing at either time of his life made him feel like this. He gets an extreme wave that doesn't subdue for an hour or so, and the only relief he gets is when he holds his arms over his head, end quote. Or this one, tested positive at home on Monday along with a family member. As of today, day 3, I'm feeling better, but long walks to the kitchen result in quick fatigue and a sit on the floor. Walking my dog has almost resulted in me laying out on the pavement. I have asthma, but my breathing is fine, but taking 2 steps will bring me to my knees as if I've walked several flights upstairs. This is my 3rd round with COVID. The vax was round 1, had me on my ass for 3 weeks, and I've gotten it twice since being vaxxed in September 2021. Fuck COVID, end quote. Finally, for now, quote, I had symptoms Saturday, fever Sunday, and tested Monday for fun because everyone around me said I had a cold. Surprise, I was right, it's COVID. Went to bed last night and only slept 1 hour as I was coughing the rest of the night, end quote. These are anecdotal, as much as the Washington Post's report was, but 200,000 infections a day puts us at nearly 1.5 million for the week. That's still a lot of people. The collapse in surveillance and preparation would naturally put millions of Americans in an understandable, if also ill-supported, comfort zone. On the other hand, the camp of COVID minimizers continues its march toward absurdist territory. Oncologist Vinay Prasad, one of the leading COVID minimizers, declared efforts at masking not only against COVID, but the smoke in New York City from the Canadian fires without a randomized controlled study were signs of, quote, an untreated mental illness plaguing public health, end quote, as if no intervention could be pursued for each new public health threat we face until such years-long study was completed. That take might speak to the quality of Prasad's COVID commentaries throughout the pandemic. Prasad's arguments run in parallel to that of OceanGate CEO Stock Rush, who, in retrofitting his submersible with off-the-shelf, out-of-date parts and no safety beacon, argued safety overrated. You know, there's a limit, Rush told a reporter. At some point, safety is just pure waste. I mean, if you just want to be safe, don't go out of bed. Don't get in your car. Don't do anything. At some point, you're going to take some risk, and it really is a risk-reward question. I think I can do this just as safely by breaking the rules, end quote. There are no regulations on these submersibles in international waters. The so-called disruptive entrepreneurs, these titans, to reference the submersible's name, switched to demanding the kind of immediate state intervention they've argued against for the rest of us during a deadly pandemic. If I don't get a very positive response from the US government by the time I wake up, declared OceanGate consultant David Concannon, the whole world will know the names of the people who do not do their jobs, end quote. Suddenly, safety isn't pure waste. The People's CDC has never thought safety should be treated so badly. That's why, given the accumulating evidence of COVID's continued dangers, the People's CDC is still fighting for COVID-safe practices, universal health care to access treatments, and broader public health overall. In these past weeks, the People's CDC has set up letter writing to tell your senators to ask the Centers for Medicare and Medicaid Services to track COVID acquired in hospitals, a data point CDC is abandoning. And the group has also pushed letters to Congress and CDC demanding free PCR testing for all, which is much more accurate than the rapid antigen test we discussed earlier. People's CDC is asking that you call your local public health department to set up free PCR testing using the increasing community access to testing program. And we'll put all these links in the video description. In other words, as People CDC's Mary Jirmanus Saba and Zoe Phil argued earlier this year, there's more to bringing about change than just posting on Twitter. Out in East Los Angeles this month, fast food workers protested against McDonald's efforts to force workers to continue working while ill. A colleague who was visibly sick was denied time off. She was hospitalized with chronic obstructive pulmonary disease and died. Health and safety are treated as much as commodities as burgers and a trip down to see the Titanic. But we won't let them do so without a fight. And that's COVID this week. You can find all our episodes on the People CDC YouTube channel. You can learn more about the People CDC and read this week's COVID weather report at our website, peoplecdc.org.